Good morning and welcome, everyone. Today is a great day. You are in for something very special today. My name is Bobby Howard, and I am currently the director of the Multicultural Donation Education Program for LifeLink of Georgia and a 28-year kidney transplant recipient. Today, I'd like to welcome you to our topic of discussion, health inequities through the transplant and donation process. Today, we have two very good speakers with us today, but of course, as we go through this morning's program, there are a couple goals that we would like to achieve today. Our first goal we would like to do is to share the health disparities that exist, discuss barriers, and share about recent policy changes that have impacted these inequities. And our second goal we'd like to do today is to make sure that everyone on this call is aware that transplantation and donation is something that's very important to our communities, but we must adhere and understand that there are inequities. We'd like to discuss some of those today. Our first speaker that we have today is a very good friend of mine, and I am so excited to be working with her again today. We have Dr. Velma Scanterbury. Dr. Scanterbury is the first African-American woman transplant surgeon in the United States. She has received many honors in her career, having been named to both the best doctors in America and the top doctors in America list multiple times. She received her training at the University of Pittsburgh Medical Center, later relocating to the University of South Alabama as the Gulf Coast Regional Transplant Center Director in 2008. In 2020, Dr. Scanterbury retired from the Christian care to pursue an academic career and is currently a professor of surgery at Texas Christian University. Welcome, Dr. Scanterbury. And our second speaker that we have today is also a good friend of mine, and I'm enjoying and will be excited to work with her today, is Dr. Tangela Purnell, is an epidemiologist and health service researcher with over a decade of experience focused on promoting equity in kidney health, transplantation, and closely related cardiometabolic conditions. She is an associate professor of epidemiology and surgery at Johns Hopkins University. Welcome, Dr. Scanterbury and Dr. Tangela Purnell. So as I stated today, we have a very important topic that we want to talk to you today. So Dr. Scanterbury, if you can start, and Dr. Purnell, you can start. Could you review some of the disadvantages that Black and Hispanic Americans face when trying to access transplantation today?
You having that wonderful welcome, and it's wonderful to be on this platform with you this morning. And, one of the things you have to realize is that when you look at those with kidney disease, African Americans are 4 times more likely to develop kidney failure compared to white population. And therefore, it becomes important to understand that that can create a disadvantage, one, in being referred for transplant. And oftentimes they're less likely to be referred at earlier stages because they also have that disadvantage of being diagnosed later because of their chronic kidney disease. And because of late diagnosis, they're often less likely to receive preemptive living donor transplant, which is important for patients to understand, is also a viable choice when you look at longevity and the ability for that transplant to last longer. So it is important to understand that for many people of color, the workup, getting on the waiting list, and oftentimes can take longer going through the process of all the testing to be on the wait list. And so many patients, while they're on the wait list, assume that they're actively listed for transplant, when indeed they may not be listed actively, and they're only listed for time, but not in the category of getting a transplant because there may be some outstanding tests that they are required that keeps them from being listed actively. And, I think Dr. Purnell also quite aware of these statistics, so she can also offer her view.
Dr. Purnell, would you like to add on?
Sure. Thank you, Dr. Scanterbury, and thank you so much, Bobby, for the warm introduction. I absolutely agree. It amazes me how even today, we often hear so many stories. Even though recently people have reached out and said, oh, I have a loved one that, we just found out that this person has kidney failure and we really don't know what to do. It was so unexpected. We often will hear stories about people who did not even realize they had any problems at all, including were not even aware of their blood pressure issues or out of control diabetes, and did not know that that could, later lead to kidney failure. And they would say, the first time that I realized this, it was in the ER. I could not use the restroom, or I felt dizzy. And then I later found out that my blood pressure was so high, or, now they're telling me that my kidneys don't work. And, they often sort of call this crashing onto dialysis. And in many ways, it really places the patient and their family at a disadvantage. One, because, this is a lot to take on. This is
Mhm.
a lot to cope with mentally, but it also, there are a lot of different steps that are needed to prepare for even trying to attempt to get through the transplant evaluation process. And you've lost a lot of time in just even learning about that process, or even thinking about trying to have a kidney specialist or a nephrologist. And that is just one of several stories that we often hear. From the provider side, we know that there are also differences in terms of timing and the quality of education about a transplant. For example, we know that Black and Hispanic patients often are referred to a kidney specialist much later. And even after they are then being treated within the context of a nephrologist, sometimes the quality of the conversations about transplant as a treatment option are different by race. We know that from the empirical evidence. We also know that many times those conversations are much shorter, and sometimes providers sort of make assumptions about which patients they believe may or may not be interested in a transplant. And again, that also sort of disadvantages the patient, because the quality of that conversation may then sort of influence the timing of when patients actually want to pursue a transplant. And we also know from the empirical evidence that the longer you stay on dialysis, the more likely you are to develop additional illnesses that, sometimes may actually rule you not a good candidate for a transplant. So again, timing is key, and really just thinking about, again, all of the different steps that it takes to get on that waiting list or to identify a living donor.
Thank you both for those wonderful answers. And I'd just like to add, I remember, when I was first diagnosed, that I was in kidney failure. And because I had a little knowledge of because my mother had a transplant, I asked the question. I don't know if I would not have brought the subject matter up about getting the transplant or being waitlisted, if I would have been afforded that opportunity. So being knowledgeable and having some kind of understanding, I think some of the things that we could do to help in this process as our family members and loved ones are diagnosed is that we have to take more control of our health care and start asking more questions as we go to the doctor. So thank you both, because you guys are right on track. And I've heard a lot of horror stories and talked to a lot of patients who've been on dialysis for so many years and never was given that opportunity or even asked the question if they want to be waitlisted or have a transplant. So, we're right on target with that. But before I go any further, one thing that I did forget, we will be taking questions, and I encourage all of our listening audience, if you do have questions, please put them in the chat. We will try to get to every question that we can in our allotted time. If we don't get to answer your question, we will try to follow up on our best ability so that your questions and concerns can be answered. So moving right along with our subject matter, I know we started off talking about dialysis and kidneys, but there's also overall health disparities and equities of what pertains to healthcare. Can you both give a brief answer on what are some of those other inequities and some of those disparities that people face?
No, thank you, Bobby, for that question. And it's important because we assume that all patients who desire to have a kidney or want to be evaluated for a kidney transplant have a level playing field, and it really isn't. And so you have to think about distance from the transplant center. If you're having someone who have to travel miles to be able to be seen and evaluated for a transplant, that may hinder their workup. It may hinder the ability to get all the tests done. So those are things that we have to take into consideration, that there may not be equity across the board in terms of being able to access a transplant center. And oftentimes patients on dialysis have restrictions, and we don't take those into consideration in terms of, not only can they get there, can they afford to get there based on their income, how much do they have to pay for parking, how much do they have for gas, it's so important also in terms of when you go through the process of being evaluated for a transplant or accessing, trying to get on the list, is that you want to make sure that your disease process has been clearly identified or delineated. And unfortunately, for many people of color, as Dr. Purnell said, you have that late diagnosis. They're finding out much later in the course that they have end-stage kidney disease. Excuse me. And so that then is overwhelming in going through the process of evaluation. They have so many things to do that they feel burdened by the number of tests that needs to be done. And so it's important also to have social support in having someone who's coming to go through the process with you. The whole day process can be overwhelming. Is there someone who can listen in, also ask the right questions? And especially with patients who may be older, and they may not be feeling great because they just came off of dialysis or need to go to dialysis. And so the overwhelming amount of information that they're given can be disabling, in that they return home and they're not sure what they're supposed to do. They may feel that the whole process is overwhelming, getting all these tests done. So it becomes important to be able to identify how can we assist patients, how can we give them the tools they need in order to go through the process successfully to get that transplant. And so many times these patients with end-stage kidney disease who are seeking a transplant also have other disease processes that may be also inhibiting them from achieving or getting the test that they need. And so they may have a higher burden of, while they're kidney disease, they're still diabetic, they still have high blood pressure, they still have to see the heart doctor. And so there's so many things that may create barriers, that it's really about working with the patient to identify how we can help them get through the process and identify a donor, as far as even getting that education about the benefits of living donation can be a barrier oftentimes.
Thank you, Dr. Purnell. Dr. Scantlebury went over some of the barriers, and are there any barriers or anything that you may have seen in your studies and your access of working with people not actually in the clinical realm, but in your work, what are some of the barriers that you've come across?
Absolutely. So, just to add on to the barriers that Dr. Scantlebury mentioned, even thinking more upstream, we often now hear about these social determinants of health and how, in many ways, they could impact our overall health even much more than our visits, to the doctor. So, what does that mean, right? When we think about the fact that we now see many reports saying, oh, well, your zip code can tell you a lot about your health. The reason why your zip code can tell you so much is that we know that even at the community and the neighborhood level, there are differences, as Dr. Scantlebury said, in access to a hospital or the transplant center, But there are also differences in other really important factors. For example, the availability and affordability of healthy foods. So, we often hear, oh, you need to eat more fruits and vegetables, or
Yeah.
you need to make sure that the foods that you are eating are not high in sodium or not high in carbs, etc. But when we think about, where many of these larger chain stores are located, often they aren't in the same neighborhoods where we see the highest rates of disease. We also know that another, sort of lifestyle recommendation is often around, oh, well, we need to engage in more physical activity. But when we look at, for example, the quality of sidewalks, the safety of neighborhoods, et cetera, again, we know that that varies by zip code and other sort of census tracts. And often, we can see a very clear pattern again around the burden of disease and who sort of lacks those basic needs. We know that housing, right, also varies. So, for example, we now know that environmental toxins can also be harmful to the kidney. So, for example, pollution, for example, things like lead paint that was still in some older homes not that long ago. So, all of these things, right, could play a role in the health of that overall community. So, when we're talking about, where we're going to find a living donor, again, many of the living donors often are relatives or close
Mhm.
friends, people in those same social networks. But if there's a higher burden of disease, if there's a higher um, amount of barriers within that community, and for example, again, looking at overall income levels, all of these things, right, play a role in disadvantaging groups of patients and groups of people. And, the other thing, which, we haven't, I think, talked as much about, is even health insurance. We know
Yeah.
that Medicare, right, kind of steps in
Mhm.
once a person is sort of on dialysis. But again, if we're thinking back to the importance of timing and the importance of early detection of issues, we don't have that same coverage, right? If you don't meet the criteria by age or other conditions, then if we have a higher proportion of people from certain groups who may be uninsured or underinsured, meaning they have insurance, but perhaps the co-payments are so high, or the premiums are so high that it's really hard to even see a primary care physician on a regular basis, then you don't have that same opportunity to sort of pick up early detection of a disease, for example, high blood pressure or diabetes or pre-diabetes. And again, that just sort of puts you way behind already before, the ultimate test, right, of trying to get through all of these other hurdles to get on the transplant waiting list ever even occur.
Thank you.
Yeah, and Bobby, I wanted to add that one of the things also, as Dr. Purnell said, is that when we think about the affordability and the fact that Medicare covers dialysis, but so very often the additional insurance that patients of color may have, some patients may be disadvantaged because what is covered by dialysis may not be the same insurance they need to adequately cover transplant as well as their medication. And they may not even have the right policy. And so many patients may be denied because one, they can't afford the medications, or they need to switch insurance and they may need to pay co-pays for something for another insurance to allow them to qualify. And meeting those daily needs of expenses can often be taxing to patients. So understanding that the financial burden can also be prohibitive to some patients become important too. And we need to recognize that. And also, as she was saying, something as simple as access to food or diet and being able to eat the right things. And many patients can be uh, disadvantage of not being able to get on the list because the hemoglobin A1C is too high. And they're told to lose weight and they're told to improve their diet without addressing the social determinants of health or those factors or those barriers that keep them from healthy lifestyle or even achieving healthy lifestyle. And so the patient is held back by not being listed because we're failing to identify those structures that are in place that prevent the patient from getting well.
You both answered that question so eloquently because you both shared some inequities and some barriers that are out there that I think our listening audience may not have even thought about. And especially when you start looking at the social realm of where people live and all those things, which I don't think a lot of people really take. We always want to hear the things from the medical side, but we don't get that opportunity to hear those things coming from just our environment and how our environment and where we live, how that can have an impact on our overall health as well. But before we go any further, if you are just joining, welcome. Welcome to this session of Health Inequities through the Transplant and Donation Process. I'm Bobby Howard, your moderator. We have Dr. Velma Scanterbury and Dr. Tangela Purnell with you today, who are giving some great insight on health inequities and how it affects people of color through the donation and transplant process. So just a reminder, if you do have questions, please put them in the chat. And I promise we will try to answer every question that you do put into our chat today. But Dr. Purnell, I want to start with you on this one. You've mentioned some very good barriers. And with some of those barriers, especially those barriers coming from where we live at in our environment, how do we overcome some of those barriers? What can we do? What can we do as just people so we are not put in those positions and get over some of those barriers that you mentioned?
Wonderful question, Bobby. I think first, it's so important for us to focus on raising awareness at the community level, meaning we often, see these narratives, for example, or, just false narratives around, oh, well, certain communities just will never sign up to donate, or certain communities just are not going to ever be engaged in this process, et cetera. But, I can tell you this, and, you both know, when you actually get to know members of communities, in particular, working with those who are already sort of trusted leaders and doing things like even outreach. For example, we know that National MOTEP has been a leader in showing us that if you actually tailor our approaches, our outreach to communities, we actually, saw exponential increases in the number of African American donors. We've seen the same thing when we started to raise awareness around all of the barriers that patients face, and sometimes very simple things like transportation. The first thing that, I've heard back is, oh, well, we didn't even know that all of this was going on. Of course, we will sign up to try and help a member of our church or a member of our community to get through this. We never even realized there were so many steps in this process, or even what it even meant. We thought, if the person shows up and passes a test on day one, then they get on the list. We never knew they had to go back and forth for appointments. We never knew the volume of, educational materials, which we can talk about, what that means, the quality of it, if it's full of medical jargon or full of very technical terms. We've actually heard from community members, for example, one pastor said, well, there are lots of medical doctors in my congregation, and any number of them who are retired now would be happy, to attend an appointment with someone. So I think it's so important for us to sort of raise awareness of these issues, to not make assumptions about communities or groups of people or patients. I think it's really important for us to try and think about ways to alleviate the individual level burden on this patient. It is a lot, right, to deal with. And in many cases, many of them may still be the primary provider in their families. They may have other things going on, like worrying about paying the rent, worrying about paying for utilities, et cetera. So as I think even members of the transplant communities thinking about some of the new changes where certain hospitals and certain health systems, for example, have begun to help patients who are having financial issues with just these basic needs. Some of them have, begun working with trying to tackle housing related issues. Some of them have begun working with trying to help provide healthy foods and doing drop-offs in convenient places within neighborhoods, et cetera. So I think it's really time for us to think creatively about what it means to be a community. I think we're all a community. Now, what does it mean for us to kind of rally around each other so that we can really try and think about how we can provide support for each other? I think that's really what's needed.
Well, thank you for that. And I think that there's a lot of things out there that we could do, and you just mentioned a couple. But I want to move forward with the question that I have for you, Dr. Scanterbury. What are healthcare professionals doing, as a transplant surgeon, and you're one right in the trenches? What are healthcare professionals doing to overcome some of these barriers, and how are they helping?
Well, thank you, Bobby. That's a great question. And it's important, as Dr. Purnell said, is that we have to bring that education and advocacy to the patient. So very many times patients have a misconception about their disease process, or one of the things that I see often is there's this stigma around being on dialysis that oftentimes they don't want anyone to know, and they feel sort of ashamed or isolated. And we try to, education is key. It's really about them understanding that there's so many others in their position. And if you talk about it, just the fact that you may educate one other person, they may now be enlightened about the whole disease process and may be more inclined to take care of themselves. And so oftentimes I say, if you just, we will come with you to your community center, to your church, to begin to talk to your community and your family about what it means to have end-stage kidney disease. What are your risk factors? What are the better options for treatment? So many people have this concept that you have to be on dialysis before you get a kidney transplant, and that is a requirement. So really talking about these perceptions that may not be accurate, allow them to understand that there are different choices that they may be able to bring through their family. And I think that education and sitting down and really talking to those patients so that they can see that this is not something that is just related to them. There are many people out there that they can reach out to their community, as Dr. Purnell said, but it's really about getting out into the neighborhoods. It's really about doing that community education, community advocacy, and testing, so that we're not only bringing to treating those who have end-stage kidney disease and need to get transplanted, but we're also educating our community about the risk of high blood pressure, the risk of diabetes, recognizing the symptoms of kidney disease, getting them to physician, understanding the importance of knowing your numbers, and keeping your numbers at foremost, understanding your risk, but also informing your family and those that live in your house about the potential risk of kidney disease, which, while it's silent, we know is much more prevalent within the Black and Brown communities. So I think for transplant centers, it's really about even in beginning to utilize our previous transplant patients as advocates to begin to work with communities, and so work with other patients who may be on the list. And that also helps when you think about people who may be have concerns or don't really understand the benefits of living donation, or maybe reluctant. Well, I'm not sure I want to donate them, because I may not be able to live with one kidney. But having them, I may be able to talk to them as a physician. But if they have someone who was a previous living donor, go through the steps with them, let them know that donated and they're doing well, all those things can encourage the donation, especially when it comes to living donation, dismiss the fears and the misconceptions that are out there. And the more we educate, the more we're able to empower patients to do better on their own, to advocate for themselves, and to seek the best treatment that they should be able to get.
Thank you. Dr. Skinnerberry, as a recipient myself, I fight and advocate for those who are waiting as well, besides the job that I do on the donation side. And I'm just a big believer that if the more people we have educating, the more people we have being advocates, from the transplant centers to the hospitals, down to the nephrologists, everybody can just get on the same page. We can get on the same page and start working more together instead of in silos. I think we can conquer a whole lot of things, disparities and inequities that we do have out here today. So I'm a really big advocate of that. So thank you for answering that question, because you're on the same line. And that's some of the things that I talk about on a daily basis, is that how can we just can't sit down, iron it out, work together, and I think we'd have better success than what we're having now, and be able to work more with some of our patients as well.
And one of the things I wanted to add is oftentimes I would tell patients, if you're afraid to speak up or to speak out, I'll be happy to come with you to your church. I'll be happy to inform your congregation. Just, pick an afternoon or a session where we'll talk about kidney disease and you can tell your story. And it's those patient stories that have touched the hearts, and allow others to say, oh my gosh, I didn't know that was happening. And it allows that story to educate that congregation, and they may, at the end of the day, have a better understanding about what the process is, and then realize as complicated as it was.
And then moving right along, I do have a question. Something just popped up that I'm seeing. We talked so much about the dialysis side. We talked about waitlisting. We talked about patients getting on the transplant list. Let me ask, what impact is the African American community has of the lack of donation? Does that have an impact on people receiving transplants, especially kidneys?
Well, certainly the more people we have donating, the more people can get transplanted. And, unfortunately, when we look at the waiting list, over 50% of the waiting list is made up of people of color. For African Americans, we make up about a third of the waiting list for transplants. But unfortunately, we don't donate at 30%. And so we still have a way to go. But certainly it's about education. It's also about getting people to understand that you have to be willing to look outside your family. You have to, many patients I talk to, they say, well, I don't have anyone in my family to donate. And I said, well, it doesn't have to be a family member. Think about those, your other circle of friends, those who maybe you went to school with, those who you work with, those in your church, in looking at resources or looking at opportunities to educate others about, especially within the Black and Brown community, to increase donation rates. And as Dr. Purnell said earlier, unfortunately, if a patient has diabetes or high blood pressure, they're going to have more people within their family may be at risk for that same disease process, which may limit the ability to donate. But the bottom line is that there's so many myths and misperceptions when it comes to donation around in the African American community that we need to talk more about it. We need to dismiss those myths, talk about what is real, and answer people's questions about why they're reluctant to donate. And I think that comes through education, sharing the wealth of information that we have, allowing others who have received transplants to talk about their life and how it has changed their life for the better, and the advantages of being able to be a donor.
Well, thank you. Dr. Now, I know there have been some policy changes, as far as with the allocation and some of the things. What impact and what have been some of these policy changes that our listening audience could be aware of?
Yeah, this is a what we call a hot time in the field. It seems like the policy window has been open, and there has been a lot of emphasis on trying to increase the number of available organs. So, for example, we know that there are way more people on the waiting list than the number of organs, in particular kidneys, that we have available. So there have been some proposed legislation around how do we increase, right, that number by perhaps thinking about how do we evaluate whether or not the quality of an organ is good enough to be transplanted, and whether or not we should make some improvements, right, in sort of standardizing the acceptance of certain organs that historically some providers may have felt were not as high enough quality. So there's been a lot around that. We know that one of the biggest topics, right, revolves around race, and how race, in particular, a Black race, has sort of been used, or, in perhaps even misused in certain clinical equations. For example, in the way that we try to estimate how well a person's kidneys are functioning. So historically, we've used sort of these clinical equations that gave a different number if a patient was Black versus if the patient was not Black, and they could have, all of the same sort of measures, all of the same sort of clinical outcomes, except that one factor. And there has been, sort of a lot of discussion and a lot of research recently around the fact that we know that, race as it is defined in this country is not a biological factor. It's a social and political factor. And many times there were assumptions being made about a person's race that may or may not have even been true. But because it's not, sort of based on genetics, it's not based and rooted in biology, it was oftentimes perhaps disadvantaging certain groups of patients. So we talk about, again, the importance of timing, the importance of early detection. And if your numbers are sort of being artificially inflated, and if that, sort of happened specifically for Black patients, that meant that, it looked like on paper your kidneys are fine, and may contribute to why it looks like in many ways Black patients were progressing faster to dialysis, or were already behind the curve in terms of being able to see a kidney specialist, and ultimately to be transplanted. And so the OPT and UNOS, which of course is sort of in charge of our national allocation of organs, has made, some recent policy changes around now making sure that transplant centers are sort of using a new equation that does not have sort of that race coefficient, is what is called, within it. So we're calling it a race-free calculation of kidney function to use to determine eligibility for the waiting list. And even more recently, they took it a step further to say that transplant centers who did perhaps use some of the older equations need to kind of go back and even recontact patients to now see if we use the newer equation, whether or not that changes their eligibility. So, lots of things sort of happening in the policy space around exactly, what it is that we're doing to sort of help patients to get on the waiting list. How do we sort of rectify, outdated information or assumptions that were made in the past? And how do we move forward also in increasing the number of organs that are available for the broader public?
Thank you, Dr. Purnell. Sometimes I think an hour just isn't enough time to really discuss some of these things that we're talking about today. And this is one of those situations, this is one of those occasions. This has been such great information because we're about on that time where we're going to open it up for questions and answers. But, I think, we needed probably about 5 to 10 hours really, to get out all the information that I think that people need to have, especially those people who have not been to the doctor yet, or maybe having some family members and who are caregivers that just don't have all this information. So we're going to turn to the question and answer part. But before we do that, just like to remind the audience to visit our resources section on the Kidney Action Week website to view additional resources related to this topic. Now I'd like to turn to the audience member for questions and answers. And please open your hearts, open up your minds. This is the time that you answer questions. This is a free and safe space for everyone who is listening to ask anything you'd like to answer. We have some very wonderful, knowledgeable panelists here that can answer just about any question as pertains to this subject matter that we're talking about today. But what I'd like to do, before that first question comes in, I'd like to start it off with the question to both of you. How has the impact, what are some of the barriers? We talked about the transplantations, and we all know that you can't have transplants if you don't have donation. So what impact, if we don't have donors, what's a greater impact, and what can we do out here to encourage those, our loved ones, our family members, and our friends to become organ, eye, and tissue donors?
Well, I think it's important for folks to really see that donating an organ is a gift. It's a gift that helps save another life. And oftentimes I tell patients, the majority of people are born with two kidneys. God gave us the ability to live with one. So that might mean that you have the ability to donate one. And you can donate one while you're living. And there's our goal as the physicians to make sure you're not at risk for developing kidney disease down the line. So we're going to put you through the ringers to really make sure that you can live normally with one kidney. And in the communities of color, it become important because so many patients may have familial diseases such as high blood pressure or diabetes, but is really the responsibility of the workup center to make sure that those diseases don't exist that put you at risk. And we're not going to take kidney from you, leaving you at a disadvantage. The other option also is certainly to really consider signing your organ donor card to allow others to donate after your death, because when we die, we can't take them with us. Everything from dust we came, into dust we will return. But there's all these myths and misperceptions around organ donation. Oftentimes patients will say, I'm too old to donate, or I'm too sick to donate, and or I may have this disease or that disease. And oftentimes I would remind them that even if your one organ may not be appropriate for donation, other organs may be appropriate for donation. So don't make that decision yourself. Go ahead and sign your organ donor card and allow the hospital or those professionals who it is their duty to decide whether or not your organs are viable for donation. And if not, maybe your tissue will be viable for donation. So it's important to really understand that you can give that gift of life, but it's also important to let your family know about your wishes so that they can also be on par with your decision when that time comes.
Dr. Scantlebury, that's the work that I've been doing these past 28 years, is empowering and encouraging our communities to get involved with transplantation and donation, because, without the general public and the general population that we have here in this country, transplantation would not be a viable option. So, I'd just like to, first of all, say that donation is alive and well, and people are donating every day, which is a blessing and a great thing. But we just need more, because each and every day, numbers of people are placed on a transplant waiting list, and they wait countless number of years. Some receive and some don't. But I just truly believe from the bottom of my heart is that the more people and the more avenues and the more organizations, more individuals that we have out there promoting donation, then we'll have more transplants. So once again, this has just been a wonderful talk. Dr. Purnell, you mentioned some of those policy changes and some of the effects that they're having on this donation and transplant field. But just to take that a little further, has these policy changes, have they been impactful? Have you seen a change in the number of organs that are being available for more transplants?
The more recent ones are so new that, we haven't yet had an opportunity to be able to look at our national registries to see what the actual impact may be. There were studies beforehand that sort of looked at the potential impact, and based upon, historical information and some hypotheses into the future, those articles sort of predicted that they will have a positive impact. But, when I say these are hot off the press, I mean, I think the most recent change was just in December of 2022. So, many of these are very new policies, and there are more coming out too. I think, was it just yesterday, when there was an announcement, about some additional recommendations or potential recommendations from Congress in this sort of, again, organ allocation and organ availability space. And, there were statements sort of coming out, from the National Academies of Science, Engineering, and Medicine that sort of talked about the potential impact. But, we really are looking at a time where, I can't remember, in the last 2 or 3 decades, even just from looking at historical changes over time, where we've seen so much of an emphasis on this field from the policy level and, sort of coming at it from both the sort of patient side and the waitlist issues, as well as from that donor side. One policy change that sort of happened in 2013, 2014, sort of the new kidney allocation system, did find that in the immediate aftermath, that, sort of allocation change was designed to basically give sort of priority, not just at the time that patients were waitlisted, but going back historically to even count the time that they were on dialysis as waiting time as well. And again, really trying to get at that barrier that we know that many patients of color were on average spending way longer on dialysis before they even made it to the waiting list. And the immediate aftermath, the data showed that allocation change did make a positive impact in increasing the number of Black and Hispanic patients who were transplanted. So we have seen, some data with some other recent policy changes in this space, but I am excited to kind of see what will unfold with these more recent policy changes.
Yes, it's amazing, as we go along and continue on this fight to make changes, to make more transplants available. Of policy changes happen, and sometimes you see things happen right away. Sometimes it takes a little time for these policies to really get in tune, to really get in effect for transplant centers and everyone to get up to speed and start looking at these things in a different way. So, we hope and prayerful that as things continue on, that a lot of these changes will have a positive impact. Dr. Scantlebury?
Yeah, one of the things, if you think about, I think it was 2021 where we had the new policy change that changed the distribution, what we call the DSA, or the area where patients were able to receive kidneys, and expand that within a 250-mile radius. So now patients will be given priority, not just in their small area related to the organ procurement center, but to expand out. Even it's been a year, and there's some suggestions that yes, there have been some increase in number of kidneys that have been allocated by expanding the region that patients can pull kidneys in from. And just talking to some of the nephrologists who've been changing what Dr. Purnell talked about, eliminating race from the EGFR. And you have to realize that the patients who are listed before dialysis, if their EGFR is around 19, 18, and they may not be on dialysis, they can still be listed for time, and they still may be listed for transplant. but often as not given transplant because they are really not as sick as those who are already on dialysis. And in applying that new formula and eliminating race, have changed many patients to give them extended years in waiting because now the EGFR turns out to be much lower than was calculated by using race, and have increased the number of years that they have been now qualified to be listed for transplant, going back many more years. And so many patients have been able to pick up more time on the waiting list, therefore giving them better access to getting transplanted.
Thank you for that. I did want to share, going back, I remember when I was being evaluated and I hadn't started dialysis yet. And there's a big myth out there that you have to be on dialysis before you are listed. And that's incorrect, because I was listed 4 months before I even started my first treatment of dialysis. But that's a big myth out there. I hear that on a daily basis almost, that I get phone calls and people asking me, and I coach them and walk them through and tell them what to do, because you don't have to be listed. So for the listening audience, you do not have to be on dialysis to be evaluated or be placed on a transplant waiting list. And, just sharing a little of me going through that whole process, which was tough. And, I wasn't overall very sick, but being able to sit in there, going back to some of the things that you, Dr. Purnell, and you, Dr. Scunterberry, share, is that I had a little bit of knowledge because my mother was a dialysis patient. So I kind of knew a little bit, but I always think back to those patients who go in, don't have any knowledge, and they're hearing about they're on dialysis they have to start dialysis, and that overwhelming of information that you get at one time. I'm a firm believer that it should be taken in stages, that the information should be provided in stages, and you actually should have a caregiver. If I had it my way, I would say that you actually have to have a caregiver with you as we walk you through this process of your health and how do you determine your health factor. But we're running very close on time. And once again, this has been a wonderful session. But I'd just like to ask, before we go, Dr. Scantleberry and Dr. Purnell, is there any two things or any advice that you two could give to our listening audience, especially those patients and family members who are going through this process right now? Any two things, any two topics, or anything suggestion that you can give, just two suggestions that you can give to our listening audience and how they can have better prepare or take better care of what they're going through right now.
Thank you so much. I think, one of the things that I always tell our patients as they come to me with questions is that do your best to understand your disease process and understand your options for treatment, because oftentimes those options may not be presented to you as they should. And the more you know as an educated patient, the more you can begin to have that discussion with your doctor about what is right for you as a patient and what works best for you. And knowing your choices become so very important. And my second thing would be what that Bobby just said. When you go to your physician and when you having these discussions, especially if you have parents or elderly people in your family, make sure, even just yourself, make sure you take someone with you. The information can be so overwhelming that you may get distracted or trying to think of a question or forget the question you were supposed to ask, that you are not listening or paying attention to what's being said. So my thing would be to write your questions down beforehand, do your research so that you can have a better understanding. And if you don't understand something, be sure to stop the doctor and say, can you explain that so that I can gain more, understand that better. Never leave the office feeling like I don't understand anything he said. That's not good. You want to make sure that there's good communication and that you can have that relationship so you leave there feeling like he's offered you the best possible options.
Thank you, Dr. Scantleberry. Dr. Purnell?
Absolutely. My first word of wisdom echoes what Dr. Scantleberry just shared. I wanted to say, don't be afraid to say, I do not know what you just said, or I do not understand the information that was presented to me. We know, especially we've seen sort of these age effects in certain communities. For example, some people who may be considered older often will just say, yes, I understand, or want to be very polite towards, their providers or others who may be presenting information, and then later on may say, well, I really didn't know what was said. I didn't want it to seem as though I was not capable of understanding this information, etc. And that's for anyone, right? I often, will tell people I consider myself to be highly educated, but I yet, still say very easily, could you repeat that? Could you reframe it in a different way? I really don't understand, this aspect of the process, or, could someone else also, work with me on this? Is there again a person who's been through this process that might be able to speak with me so that I can ask continued questions, et cetera? So again, definitely don't be afraid to be an advocate, to be your own advocate for that life-saving information that could really make the difference between whether or not you make it through this process. And then the second, sort of word of advice is really for the broader sort of community. I consider community to be every single one of us who's here today. Even if you're not a patient, even if you don't directly know someone who is a patient, we are all members of this community. And as I tell, my students, when we're talking about how do we advance health equity more broadly, I want to say, find somewhere to fit into this story. You may not immediately get a request from a person going through this, but find a way to help. Find a way to jump into this fight, and find a way to use your own skill sets, your own resources. Maybe you are a person who doesn't take no for an answer. And maybe you will be the perfect person to pair up with a patient who is confused and is afraid to ask for help, or afraid to talk to potential donors. Maybe you're someone who's very policy savvy. Maybe you're someone who's seen as a community leader. Whatever it is, and whatever skill sets you have, we all have, I think, a role and a responsibility to jump into this fight, to try and rectify, these barriers, to try and, just really make this a better experience overall for people and families going through this. But more importantly, just so that we can have a healthier overall population and society. So that would be sort of my final word, is jump in it, jump into this fight.
Thank you, Dr. Purnell. I think I have to. My first one would be for all those who are patients out there, is that if you are diagnosed and you're a patient, this is not the end of your life. Be great at what you do, enjoy life to the fullest, and have fun, because life isn't over. I'm a firm believer that the mind tells the body what to do. And if you focus yourself on living life to the fullest and enjoying, you will get through this process. Either you are going to receive a transplant or stay on dialysis, but you have to enjoy life. My second nugget is be great. Be great at what you do. Be great at being you. Be great at being a family member. Be great at being a friend. Be great of whatever it is that you desire to do. Just be great at it, because that's all we have. We only get one shot at this life. Be great at it. Once again, I'd like to thank our panelists, Dr. Velma Scanterbury and Dr. Tangent Purnell. What a wonderful, wonderful, wonderful session that we had today. Thank you guys so much. It's truly been a joy working with both of you once again. I know we'll work together at another point somewhere down the line, or some other place that we'll work at. I also want to thank our audience, because they didn't have to be here today. They took time out of their busy schedule to hear this very informative session that we had today. Thank you so much from the bottom of my heart. We thank you, we pray for you, and we love you. Our next session that we have today is called Clinical Trials: Why Your Participation Can Lead to Advancements in Kidney Disease, at 11:50 a.m. Central Time. Follow us on Facebook or send us an email through kidneyfund.org to find out about resources like this. Once again, thank you, and please enjoy the rest of the day. And please don't log on for our next session.